look at something you haven't been at a meeting for, you can find it.
And we want to give a few disclaimers as always, that this is not medical advice. If you are concerned about any of these conditions, talk to a doctor. And since we are having patients and medical professional speakers today, that these people's experience don't represent everyone with their condition.
So we're focusing today on generalized anxiety disorder, GAD, depression, medical PTSD, and medical trauma, and how chronic illnesses are related to these conditions.
And as always, content warning, we won't be talking about very many specifics, but just in case, we want to always give a warning.
So how are chronic illness and mental health related? So a lot of people with chronic illnesses do have mental health issues as well, but a lot of them are also diagnosed with mental health issues before they're actually diagnosed with their conditions. So this can be because of a lot of different things. A lot of cases of medical gaslighting come into play as well. So there's for example, with POTS, we briefly talked about last week, postural orthostatic tachycardia syndrome. It's very common for people to get diagnosed with mental illness before getting their real diagnosis. So like the big POTS survey reported that 77% of people were told that their symptoms were caused by a psychiatric disorder or a psychological problem before they got diagnosed with POTS, and 37% of them were treated for that condition, which is very similar to the natural population of those conditions.
Why are we focusing on these topics? Because often with people with chronic illnesses experience medical gaslighting, ableism, and some experience medical trauma. So just to give a few definitions, medical gaslighting is a form of psychological abuse. It's being manipulated by doctors, dismissing you in some way, such as blaming symptoms on psychological factors, downplaying symptoms, assuming a diagnosis, refusing treatment, or a whole host of other things. Basically want you to question what you think, and that they want you to think that it is all in your head. Ableism is discrimination in favor of non-disabled people, and the idea that non-disabled bodies or minds are inherently better than disabled bodies or minds, and it's built into our society. Medical trauma is trauma that occurred in a medical setting. While not an official diagnosis itself, medical trauma can lead to conditions like PTSD, anxiety, depression, or chronic pain.
So some takeaways that we had from last meeting that we went over is try to be empathetic towards others. You never know what they're going through or have been through. And medical trauma is real. Too many doctors and medical professionals do not take their patients' concerns seriously, which not only delays diagnosis times, but also causes physical or mental harm in some cases. And mental illnesses are just as important as physical illnesses. They often go hand in hand, like we talked about. If your mental health isn't great, your physical health probably will take a hit, and vice versa. So generalized anxiety disorder is not just anxiety. It can be debilitating and extreme. It's not a typical everyday anxiety that everyone has anxiety and goes through things, but this is to a different level than everyday. And there are many different types of depression with many varying symptoms. So there's a whole spectrum, and mental illnesses can sometimes also cause physical symptoms, which can be part of the reason why doctors tend to lean towards mental illness before they look into other physical factors. And also be kind to yourself and what you've been through. You're here. We keep going every day. We're, living life. So our special guests today, if you guys would like to introduce yourselves, we have Laura, Bethany, and Shannon as our patient guest speakers today. If you guys want to briefly introduce yourselves.
Hi, I'm Bethany, and I have medical PTSD and severe depression. I used to think I had generalized anxiety disorder, but I just have really bad PTSD. And I also have mast cell disease and Ehlers-Danlos syndrome.
Hi, I'm Shannon. I have POTS, IBS, which is always fun to admit. And then as far as mental stuff, I have very, very severe depression, which is thankfully in remission, anxiety, OCD, ADHD, and then I was just recently diagnosed with PTSD.
Hi, I'm Laura. I have a whole host of medical problems, but my mental illnesses are depression, anxiety, and OCD, and probably some medical trauma in there or some PTSD. We're not quite sure. We're investigating that at the moment. Yeah.
You're
So,
muted.
You got. Unmuted?
Yes, I can't hear you.
Can anyone else hear me?
Now I can hear you.
Yeah, there we go.
Because I didn't click anything. So, what was your guys' experience with mental illness and chronic illness and pain? Like, how do those two go in hand with each other? And how do you kind of manage both?
Well, sorry, I always hop in first. To kind of like piggyback off of what you guys were talking about with the diagnosis delay. My diagnosis was delayed for 10 years because I first received a depression diagnosis. And when I would go to all of my doctors and I would tell them my POTS symptoms, which were tachycardia, like chronic pain, all those great POTS symptoms, all of my doctors would see that I was on antidepressants, and they were like, "Oh, you're just more depressed. You need to get a meds check." And they sent me back to my psychiatrist. And after 10 years of that, my psychiatrist was like, "I'm doing everything right. They're doing something wrong." And he had said, "I think you have this thing called POTS, and you need to go find a cardiologist who's going to validate me." And soon, sure enough, I found a cardiologist, and within the first tilt table, they were like, "Oh yeah, you have POTS." So that was 10 years of doctors, they just saw the one prescription and they're like, "Oh yeah, all of these other symptoms, which were very, very clearly POTS, were something else." And now that psychiatrist has identified POTS in over, I think 200 patients.
Wow.
Who have been sent to him over the last like 8 years. But to go back to your question, for me, my depression, my anxiety, all of that, and my POTS are separate, but they do exacerbate each other. So on a day when I am symptomatic, nothing feels good. I am cranky and not fun to be around.
Yeah, and to go off of what Shannon was saying, I had a very similar experience of because I have EDS, so I was born with my condition. I had symptoms as a child, my entire childhood, and doctors chalked it off to anxiety. And I wasn't diagnosed with a physical illness until I was 17 years old, but I was in a psych ward for anxiety related issues when I was 13. And they couldn't diagnose me with a mental health problem, actually. They couldn't figure it out. They were like, "She seems okay, but then she's not okay." And along the way, I have POTS as well, but I have hyper POTS. So my adrenaline just shoots through the roof, and it activates my PTSD. So if something activates my PTSD, I start fainting. So for the longest time, the doctors thought, it was the same thing, that the PTSD was making me faint. And so there was definitely a big diagnosis delay for me as well, of just trying to get answers. And then once I was diagnosed, and now that I have the diagnosis, there's still that initial, the first time you see a doctor, you don't know if he's going to try to blame everything on the mental illnesses anyways and discredit all your physical symptoms. So it's like there's never really a point where you start having, you stop having them disbelieve you. It seems like doctors will continue to fall back on the mental illness as a encompassing thing because it's just almost easier for them to explain. For me, it's always been anxiety. They just blame the anxiety for everything. Anxiety causes pain, it causes POTS, it causes this, it causes that. But obviously we found out that's not the case, and they tend to play off of each other, which does make diagnosis more difficult for sure.
Bethany, for those who don't know, can you describe what EDS is?
Oh yeah, sorry. Ehlers-Danlos syndrome is a connective tissue disorder that just means all of the ligaments in your body are overly stretched and loose. So you have a lot of joint problems, and sometimes you have issues with your organs, and you have issues with different nervous system problems. So it's a very widespread diagnosis. It encompasses a lot of different problems, but the main basis is that your connective tissue is just messed up.
And Shannon, since you brought it up, for those who don't know, can you describe what POTS is?
Ooh, let's see if I can do this in under a minute. POTS is a neurological condition where your autonomic nervous system, which controls the automatic functions of your body, so POTS is a form of dysautonomia. Your autonomic nervous system, which controls the automatic functions of your body, your heart rate, your digestion, even things like your pupil dilation, the constriction of your blood vessels. That nervous system just kind of stops working. So with my particular form of dysautonomia, which is POTS, when I stand up, my brain doesn't send the message to my blood vessels that they need to tighten to send that blood back up to my heart. And so my heart just starts beating way too fast, and then triggers a litany of other symptoms throughout my body. And that's kind of,
Yeah, usually also associated with blood pressure drop, brain fog, dizziness, a whole heck of a lot of other stuff.
yeah. And forgetfulness when I talk.
Yes. Yes, so all 5 of us actually have POTS. Okay. So how were you guys diagnosed with your mental illnesses correctly?
Do you want to go?
I mean, we haven't heard from Laura. Are you?
Okay. Actually, my diagnosis story is very different. My physical illnesses were diagnosed first, and then my mental illnesses were diagnosed, I believe I was 19. And let's see, I was diagnosed with anxiety and depression, and I'm trying to remember now, by a really very, very strange psychiatrist who thought my depression at the time was worse than my anxiety. It was actually the other way around. I was being mistreated, which caused a whole host of problems. But then I got with a better psychiatrist who finally got me on the proper medications and said, no, your anxiety is worse than your depression. Then she also diagnosed me with OCD. And ironically, my dad has all 3 of those illnesses as well. So it's kind of genetic for me.
For me, depression, anxiety, all of those kind of clusters of mental illnesses run on both sides of my family. So my parents kind of joke like there was nothing we could do. It was going to happen. I was diagnosed first with anxiety very, very early when I was about 10, newly 11 years old. And then for me, it's just been kind of like this progression over time of, as I got older, it was either, you can either look at it as either revealing new diagnoses or gaining new diagnoses. I think it's just revealing them as, you know, we look at more layers, because I think I've had everything this whole time. But, you know, we've just been learning more about me and how I function in the world. And I think that that is probably true of a lot of people of, you know, we figure out one thing first, and then a couple years later after, you know, trial and error and therapy and stuff, and then we're like, hey, I think something else is at play. So it was first anxiety, and then, oh, depression. And then there's very strong OCD, and then there's ADHD, and then it just kind of transformed. And then I was also like, it was just 2 weeks ago, I've been seeing a psychiatrist. I've been seeing mental health professionals for 20 years, and I just got a PTSD diagnosis. So it's, I mean, your mental health is something you work on for as long as you're alive.
Yeah, for me, before I was diagnosed with my physical symptoms, they blamed everything on anxiety. But while they were looking into my physical symptoms, they sent me to, and I haven't talked to a lot of people who have done this, but they sent me to a neuropsychologist, which is basically a psychologist that does this very extensive exam on your brain to find out if you have any sort of psychological problems, like even learning disabilities and stuff. And she was the first one who caught, like, out of all of my other doctors, she was the first one who caught it and was like, you have really severe depression, like very severe depression. And she was like, I don't know how you're still smiling, because she called it the Pollyanna type depression, because I always seemed like happy and cheery, but like all of my test results said I was depressed. So after that, I saw a psychiatrist who started me on medications to treat the depression. It actually did help a lot. And that same psychiatrist eventually diagnosed me with medical PTSD as well, and has been treating me ever since then. So yeah, it was sort of like in the process of getting the physical diagnosis, we accidentally stumbled across the mental health one.
I like the accidental diagnosis title.
Yeah, pretty much.
So what helps you guys the most with your mental illnesses? Like, what treatments have you tried? What worked for you? What didn't work? Has anything helped you to a degree where it also impacts your chronic illnesses in a positive way?
The treatment for me that quite literally saved my life was transcranial magnetic stimulation, TMS. I was in a place where my depression was getting progressively worse, to the point where I could barely leave my bed were it not for the fact that I had to eat and use the bathroom. And at first, my psychiatrist wanted me to pursue electroshock therapy or ECT, electroconvulsive therapy. And I was like, oh my gosh, no way, no way, no how, that's not happening. And then I actually like sat down and talked with my therapist and my family, and we did research on it. And we were like, this feels good. So we started going to my other specialists. And my cardiologist who treats my POTS, he was like, no, you're not having this. Your POTS is not in a stable enough position to do this. We need to stabilize you more, and then maybe we can talk about this later. And when I heard that, I was just like deflated. I was like, I spent a whole summer trying to decide this, and now you're telling me no. But then a year later, we learned more about TMS, found out it was approved by insurance. It is outrageously expensive, if not, which is just horrible, because I'm so pro TMS. I'm very sorry. I'm very biased here. And we got it approved. And within what happens is you go in, and it's like this MRI strength magnet, and they have like three main different machines, and they place this magnet. One form is like a helmet, one is kind of like this little thing that sits against your head, and there's another one that's like this other weird contraption. And they send magnetic pulses to your brain. Sounds fake, feels like tapping on your head, and it literally stimulates your brain to help alleviate depression. Thought it was fake, but within 6 weeks, I went into remission from depression for the first time in my life. I did relapse. I will be completely clear, and the relapse was terrible. But my doctor worked with me over the course of the next year, because he took an interest in my case, to continue giving me TMS on different protocols, because he's just kind of a quirky guy who really loves the science. And it brought me into full remission, and I haven't had like a full relapse in 5 years.
Wow.
I do not have anything so great as TMS, unfortunately. I have done therapy, lots and lots of therapy, and it's helped some, but not much. I just recently started doing EMDR therapy for my PTSD, and that's helped a lot with some of the like triggers and the really severe panic attacks that I have. But it's not great. My psychiatrist put me on a medication that's kind of like experimental, that actually has worked really well, and that's helped a lot with my PTSD. But besides medication and therapy, I unfortunately have not found an awful lot that has helped. So I'm still very symptomatic, and unfortunately still in the process of trying to find something that works well.
What about you, Laura?
honestly, the thing that has helped me the most is therapy. With the addition of Zoloft for my depression, and hold on one second. Sorry about that. Yeah, so therapy has been kind of my saving grace. Like I've continued. I actually was out without a therapist since December, and just got a new one last week. And in that time frame, I did not stop taking my medication, of course, because that's a very bad idea. So my depression got 10 times worse. And well, maybe not 10 times, that's probably an exaggeration, but it got a lot worse. But in between therapists and yeah, so that's my case.
I do.
Non-medication type things have helped any of you guys?
Sorry, what was the question?
Have any non-medication type things helped you guys?
I do have one. I got a service dog, which is a Bernese Mountain Dog mixed with a poodle, and he's 80 pounds and he's sitting at my feet. And my PTSD is like, I get like a lot of fear that someone's going to attack me or something like that. Like that's one of my biggest triggers. So he's lovable. I don't think he would bite anybody, honestly, but like he makes me feel like he could bite somebody. So like he helps a lot, and he does like deep pressure therapy and panic response and everything. So definitely I'm a big supporter of service dogs and like service animals. They help a lot.
Sorry.
On that one. My service dog has been a saving grace, and he's just always rooting for me, so it's impossible to really feel like I want to leave because I don't want to leave him. And my bunnies are the same way. My bunnies in particular. Yeah, I have too many Rexes. And one of them especially is very in tune with me and knows he knows when I'm not doing well, and will come like start biting his cage and rattling it so that I come over and pet him, and it's like the biggest serotonin release ever.
Yeah, rabbits are good. I have a Netherland dwarf bunny, and he's the same way.
Yeah.
I second and third the therapy thing. Part of TMS is they don't let you do TMS without aftercare, whether it's therapy or psychiatry or both, which is what I do. So big on therapy. I also really love, I really like journaling a lot. I usually just like furiously type things into my notes app on my phone and then delete it before I can accidentally tweet it or something like that. And just small things to like help me cope with anger, like taking a piece of paper and shredding it up really, really fast when I am furious. And I will finding ways to make myself feel really safe when I am super vulnerable. So literally like wrapping myself up like a burrito in a blanket and then getting under a weighted blanket and then getting more blankets on top. Like just finding like what your triggers, or I don't think like a trigger, but like your anti-trigger of like what makes you feel like, oh, I am safe here and nothing can hurt me, and just leaning into that as much as you possibly can. And chocolate.
And chocolate. That's I don't want to break up this great conversation here, but I do want to introduce our health professional speakers, because I know Seema has to leave around 8:10. So I want them a chance to speak as well. So
real quick before we do that, all of you give me like a second of what advice you would give to someone with a chronic illness who has a mental illness or suspected mental illness?
Take it seriously, see a therapist, see a doctor, get it checked out. Don't leave it unattended. Take it seriously. That's the biggest thing. Because I see a lot of people with mental health that they don't take it seriously and they wait it and they put it off, but like it needs to get checked just as much as a physical illness does.
I second Bethany on that one. And also remember that mental illnesses are chronic illnesses and therefore need to be taken seriously.
Mm-hmm.
Yes to both of those. That's a lot better than what I can come up. Stop blaming yourself, because I'm gonna guess that every single person in here, if they have a mental illness, or also if you're just a person in society, you are blaming yourself for something that you don't need to. Stop feeling guilty, because guilt is useless. And just be kinder to yourself, because you really need it.
And we can come back to more questions later too, if we have time and we want to do more. I just want to make sure that Seema can also share expertise too. So Seema and Dr. Wright, would you guys like to introduce yourselves and what you do?
Sure. Dr. Wright, would you like to go first, or do you want me to go first?
Why don't you jump in?
Okay. So yeah, my name is Seema. I'm a licensed clinical social worker. My role, I think when you guys reached out to me, I do private practice in the private sector, but I'm actually also a psycho-oncology therapist at University of Chicago. So I work in the psychiatry department with the psychiatrist and the oncologist. So all my patients are dealing with some sort of chronic illness, whether it's a terminal type of chronic illness or something that they beat and have to live with. So that's a little bit about what I do and kind of where I'm coming, the lens that I come from.
So I'm Dr. Jenny Wright. I'm a clinical psychologist exclusively in private practice at this point. But I did my many years ago, I did my internship through what is now Laurie Children's for medical psychology. So along with child clinical, but so the chronic illness is not, something that I advertise as a specialty, but over the years, it's something that we just see a lot of. We see kids and teenagers and young adults. You're going to see a lot of people come your way with chronic illness.
How does your job help people who have mental illness related to their chronic illness? What do you do differently when treating people with chronic illness patients versus people who just have mental health, which is can sometimes be chronic too? What do you do differently between those two types of patients?
I think for me, it's a lot of validating and kind of exploring, what their diagnosis is and how it impacts their life. There's always this sense of like normality that people struggle with. And part of chronic illness is like, what is normal? And then you have to, a lot of times people don't ask themselves that question. And then when you really start thinking about it, there is no normal. You create your normal, and so it's a lot of finding what new normals are. It's about accepting and coping with that. So I use a lot of the new wave therapies when it comes to working with chronic illness.
I would say that the vast majority of therapy is probably similar to the therapy you do with, any patient who comes through your door. However, what I think is most different is the first couple of sessions. And you guys have already spoken to this better than I can, but I find that it's incredibly hard, especially for teenagers, but it's incredibly hard for them to have to tell their story again. Because by the time they're sitting in my office, they've already told this story at least 20 times to people who haven't been able to help them. And so you're a very tough audience, but rightfully so. And so I try to, really, I take really detailed notes, and more than in other situations, I try to review those notes before I meet with the person a second time and try to be very respectful of the fact that it's really hard to tell your story a gazillion times without, finding a solution that, and of course, what you guys have said, that a lot of times, and again, I see a lot of teenagers, the referral feels like, they're telling me it's all in my head, or they're telling me I'm crazy. And so it's not an easy referral for a lot of people. For some it is, but for many people it's an offensive referral for some people.
So, do different types of mental illnesses present differently? Like, can you immediately notice the difference between different types of mental illnesses that you come across, and how do they differ?
Yeah, I would definitely agree with, I feel like they do present very differently. And to Shannon's point from earlier, Shannon, you had mentioned, you're finding a new diagnosis or something new pops up. I hear a lot of my patients tell me it's a different level or a different type of anxiety or a different type of depression that they may be feeling with their chronic illness. And so a lot of times this is the first time especially when they come into my office, they may be experiencing this for the first time. So it's helping them uncover what they're experiencing, kind of processing and sitting with it. This is a really unpleasant feeling. No one wants to sit with this, and being able to do that with them is an honor, really, but it's to help them move forward.
Yeah, and I'd add that, and again, you guys know as much or more about this than I or we do in so many ways, but the relationship between the physical illness and the emotional disorder, it's bidirectional. And so when somebody's coming in, you're trying to figure out, it's kind of a chicken and egg, and it doesn't really matter. But if you feel like it's the emotional, like the anxiety or the depression or something like that, that is really exacerbating, sometimes even causing, but at least exacerbating the symptoms, then you're going to work hard to try to fix that first. If it's more that there's been a really difficult diagnosis, it's more about coping with. You guys have many. I don't know if each of you, it's very common for people to come in with both anxiety and depression, but those present very differently in terms of approach to illness. So somebody with OCD or anxiety may be like hyper focused and trying to get a lot of answers and very involved, sometimes over involved. And then somebody with depression may be more hopeless and more disengaged from the process. Somebody with bipolar kind of fluctuates in mood, may be very inconsistent in their approach to their illness. So understanding those things can, kind of keep you on your toes and hopefully be focusing on the right thing.
How many patients with chronic illness would you estimate that you helped at this point in your careers? If you can put a number on it. If not, that's totally.
It's kind of hard to answer, right?
Go ahead.
No, go ahead.
I was just going to say it's really hard to estimate because I saw a bunch for 1 year at the Children's Hospital, and then I've been in private practice for closing in on 30 years. So with that together, I would say probably 150-ish, maybe.
Yeah, I would say I see a ton right now because all my patients are going through cancer, right? All of them are either terminal and dying or just starting their cancer journey and are gonna have to live with this forever. And then I also see people in private practice who have lupus or chronic migraines or a chronic pain and so it really fluctuates, but I would probably say about the same, maybe like in the hundreds. Not, maybe I've been doing this for a while at the hospital. So maybe maybe 100 and plus. I can't really put a number on it though.
It's hard.
What is the most challenging about your jobs about treating patients with mental illness and chronic illnesses? I know you just mentioned like you have a lot of terminal patients that must be challenging to try to navigate.
Yeah, I just had a case today where one of my patients is wanting an answer for what she should do next. She has tried one type of therapy, one type of chemo, and she doesn't know if it's going to work. It's kind of like what Dr. Wright said about the OCD and finding control and finding something to grasp onto during this really, really turbulent time. And she was asking me if she should just throw in the towel. As a therapist, what do you say to that, right? How do you sit with that? And I have to remind her every time. I meet with her every week, and I have to remind her, we're going to find that out together. You've told me you're going to give away your dog. You told me you want to pack up. Seems like you've got an answer. You know what you want to do, but you're afraid to say it out loud. And it's okay to sit with that. It's okay that we don't have an answer right now. We'll get your oncologist involved. We'll get your psychiatrist involved. But they have to come to that decision, right? Just as patients, we have to make decisions on our own. As much as our doctors and providers want to guide us, we have to be our own advocates a lot of time. And that's probably some of the most difficult part of doing psychotherapy with chronic illness, is that we are often the ones encouraging, but also kind of helping them navigate how they want to say things, how they want to distill questions, right? Because especially with chronic illness, you have so many questions running through your head. How do we distill that down so it doesn't come out like a word vomit a lot of times, in clinic?
It sounds incredibly heavy, and I see very few people, facing death. I would say for me, the challenge is kind of always trying to have that balance of you have to be accountable. You have to take some charge of your well-being, and you also have to not take blame for all of your well-being. And that is it's a very thin line, it seems sometimes, between, taking too much responsibility and taking not enough responsibility. And to remain, again, very respectful about why that happens, because it's not surprising it's a very hard mix. And looking at progress and improvement as, it can be very small steps. It can be sometimes it's hard to convince somebody that sitting at the dinner table for 10 minutes is a success to celebrate, when what they want to do is be able to eat an entire dinner with their family. And so, and as hard as the therapist, you want your person to be doing better. So it's always staying kind of humble to the process, because it's a slow one for most people.
So what would you want as a wrap up for patients to know about mental health as it relates to chronic illness? What would you want the general population to know about mental health as it relates to chronic illness? What do you want other doctors and physicians to know when it comes to mental health and chronic illness and how they meld together? Just like a general, what are some important takeaways about these two things relating together?
I would say when it comes to what I would want patients to know is, this is going to sound crazy, but start early. The moment you notice something's off, you can certainly talk to your doctor, but you can also start talking to a mental health provider, right? Being able to kind of sort out some of the kind of anxieties that you may be experiencing. What your doctors, what I may want doctors to know. I've been really blessed with working with a bunch of oncologists that just love psychotherapy and love to get involved, love to get my patients involved in psychotherapy very early on in their cancer journey. So we see the shift in mentality. One of my patients just got diagnosed with breast cancer, and we already know when she gets her double mastectomy how difficult it's going to be, preparing for some of these things like tapering expectations. But I would want primary care physicians to be more aware of how mental illness plays into the general public, more education around that. And so I think that's probably the hardest part. As far as the general public, people present very differently than what they may be feeling inside. So I think someone had mentioned it earlier, but you never know what someone's going through. You never know what battle they have going on right now.
Yeah, I would ditto all of that. I see the three as very combined. What should providers know? What should the general public know? What should patients know? For the general public, and you guys said it earlier, for both chronic illness and for emotional illness, it's usually very often an exaggerated form of something that everybody experiences. So clinical depression, people will think, oh yeah, I know what it's like to be depressed. Or somebody who gets migraines, I know what it's like to have a headache. And so general public believes they understand, and they believe they know perhaps even advice to give. And it's important for for everybody to kind of know that you probably don't. And professionals, you know, be easy with the diagnosis, be easy with the referral, explain the referral. You know, I've met people who realized they were referred to me because it was on their patient notes, you know, their aftercare visit notes, like go see Dr. Wright, and they had no idea what it meant. For the people with chronic illness, and I hope I can explain this well, I think there has to be a lot of forgiveness for the rest of us, not for our sake, but for yours, because it's so easy to be angry at the person who says, oh, well, you get headaches, I get headaches too. It's enraging to hear that from a person who doesn't get it at all. And it's enraging to hear a professional ask again about your anxiety when it's not necessarily about your anxiety. For the patient's sake, it's really important to let some of that anger go and to try to remember that people are, for the most part, not everybody, but for the most part, people are trying to do good, and they blow it. They blow it significantly, right? I mean, I remember trying to get pregnant. Well, just relax. Like, okay, more than that. But you know, but it's really easy to get angry and to carry that. And for your own sake, if you can see people as trying, they're not always their best, but for a lot of people are really trying to be helpful. And I think sometimes that relieves some of just that churning that you can carry with you. And I hope that's not offensive to anybody. I think it's just an important thing for people to know.
Yeah, I mean, actually, to kind of piggyback off that, Dr. Wright, you know, fun fact, I too am a cancer survivor. So I know and I never disclose that actually to my clients. I never tell that to my patients because it's not about me. It's not about my journey, but their journey. But I do tell them I'm passionate about what I do because I've been there. I know those feelings intimately.
Mm-hmm.
So you're right. You know, it's nice to have a provider who may be coming from that lens, but you don't know what your provider may look like. And so having that compassion, having that grace until you get to know that person a little bit more, until you're able to find that right provider who's going to be able to hear you, to validate you, to help you in the direction that you want to go and that you feel the safest is so important.
That's a really great point because, you know, I haven't read the research recently. Most of the time when there's been research about success in therapy, it's about a good match between, you know, patient and therapist. It has nothing to do, not nothing, but it has less to do about what kind of therapy and how much education, what degree do they have. It's really about a really good match. And I may be a great match for somebody and I could do the exact same thing and not be a good match for somebody else. And as the patient, the client, I am never offended when somebody says, you know, I'm not clicking. I would much rather somebody find the person that they click with and not give up.
So does anyone, both in person and on Zoom, if you have any questions, please type it in the chat or tell it to me.
And for both of you, I have one more question. How did you get into this field?
I did my undergrad in psychology and loved it. I worked in the nonprofit sector for years in child welfare. But then I actually went to Loyola for my MSW. So shout out there. And I did my internship, actually my second level internship at Larry Children's. So I kind of fell into medical social work. And then now I've been at the University of Chicago for a number of years, but I started doing this for a while ago and have always loved it. So that's kind of how I fell into this particular arena. And then having cancer sort of solidified it for me.
Yeah, I started saying in like probably 7th grade, you know, I think I want to be a psychologist, but I'll probably change my mind. And, you know, had some mental, not anything terribly serious, but some, you know, emotional stuff in the family. And got to college and I declared my major as psychology, but I'll probably change my mind. And then by the time you go to grad school, it's like too late to change your mind. But so it was just interesting to me. And then the medical part, you know, I went to the Children's Memorial, now Lurie Children's internship because it's an excellent internship and I got in. So it really was for more the child family, you know, clinical stuff. And then part of that internship is the medical psychology. So that just, again, it's not the only thing I do, but it certainly was a new field for me and one that I just was very interesting, hard, but very interesting.
If anyone has any final questions or comments, either from guest speakers, both patient and otherwise, if you have questions for each other or anything you want to add before we wrap up?
And feel free to ask any questions in the chat for our audience.
It's kind of a question, kind of a comment. Somebody had mentioned the EMDR. Bethany, was that you? Yeah. It's an underused treatment. And one that I've been trained in, and I don't use it very often. My partner, and who's also my husband, does. But that's, yeah, I'm glad to hear that. It was a good kind of reminder.
Yeah,
I put in my little note.
I struggle really badly with nightmares for some reason, like night terrors really badly. And the EMDR has helped a lot with that. They've gone down significantly. And then when I do have them, I can like lucid dream myself out of them now. So it's definitely, I wish I had heard about it years ago. I don't know. It's something I just heard about from a friend who did it like last year, but it's been very helpful for sure.
Those who don't know, could you explain what EMDR is?
I think Dr. White would be better at doing that.
I don't know. I'm not so sure. It stands for eye movement desensitization and reprocessing.
I think so.
Basically, it's a treatment specifically designed for trauma, although it's now used for just improving life and performance anxiety and everything. It's very, I don't do a good job of explaining it, but basically, with trauma, we remember it with words, we remember it with physical feelings, we remember it with images. And this is a process, and it uses a movement of your eyes to help bring up memories in a safe way, to reprocess and realize primarily what are the things that you learn to say to yourself as a result of the trauma that you carry with you, and you don't even realize it. It was found by somebody who realized that when she was talking to people about their trauma, they would kind of move their eyes back and forth as they processed it. The idea is that the two hemispheres, more emotional, more cognitive, work together to help kind of reprocess the trauma. How'd I do?
I feel like that's a good explanation.
Seema, you may do better.
Yeah, it's a good explanation. I did think it was like, I do it over telemed. So some people do it in office, and they do it with like machines that like help the rapid eye. We do it with my therapist. We do like tapping. So it's really interesting because there's a lot of different ways to do it. That's the only thing I would add. There's a lot of different ways you can do the rapid eye movement. And my friend has had to try like 5 different ways to find one that worked for her. I seem to be okay with the tapping, but it varies for everybody.
Yeah, I hear that it's people are using that modality a lot more for a lot of like trauma work too, which is phenomenal. I mean, I love the ask because I worked in a hospital for a number of years, and we would suggest that to our patients who experience like violent traumas, but I've seen it work really well even with medical trauma too. If people experience medical trauma.
It's one of those treatments, kind of like you were talking about with the PMS. It's when I first heard of it, it was an eye roll kind of thing, because here you are, you're doing this, and the patient's supposed to watch it, and and then tell me how you. It seemed like one of those kind of kooky. It is remarkably successful. It's pretty phenomenal.
Yeah, we use it for my medical PTSD, but I have a lot of like childhood trauma that I don't remember very well. I just remember sensations and stuff. And it's the only thing that we found that lets me process that sort of memory. So yeah, it's really good. I'm glad that it's becoming more well known.
Well, thank you so much to everybody for coming out and being guest speakers. We really appreciate your expertise and experiences and your time. So thank you so much for coming and sharing everything with us. We really appreciate it.
You're very welcome.
Yeah, you're welcome. If you have any questions, you could always email me too. I'm more than happy to answer those as well.
Thank you so much for everybody for and joining us today, and we hope that you got something good out of it.